Good evening, friends. Sorry for the delay. Today, our Secretary Ubal has organized a star night with galaxy of stars. Respected patrons, KRP sir, Bala sir, and stars of the day, Professor Mathan, Rakesh Tandon, Professor Nagi Reddy, Professor TSC sir, who have received the Master of World Gastroenterology Organization Awards, senior members, teachers, students, and friends. It's my proud privilege to welcome you all for the wonderful academic feast. Today we have a postgraduate session followed by lectures by the stars of the day and a panel discussion by our senior members about the future of gastroenterology. I welcome you all once again for the wonderful evening. Thank you.
I call the chairpersons for the PG session, Dr. Ganesh, Dr. Venkateswaran, Dr. Revati, Dr. Aravind, to come over and...
Good evening, everybody. I call upon Dr. Noble Matthew from Rajiv Gandhi Hospital to present this case. I request all the presenters to be brief.
Good evening, teachers and dear friends. I'm Dr. Noble Matthews from MMC. I'll be starting off my case. Mr. X, 65-year-old male, a known diabetic on OHAs, presented to us with a history of 1 year of melena, fatigue and exertional dyspnea of 6 months. Melena was intermittent, anemia requiring frequent blood transfusions, no abdominal pain, no other bleeding manifestations, no loss of weight or appetite. Multiple hospitalizations requiring blood transfusions, around 18 units of packed red cells were transfused over a year. Short-lasting improvement in HB, followed by recurrence of anemia. Past and treatment history, a CVA thrombotic right MCA tertiary infarct 4 years back and is on antiplatelet ecospirin for that. He takes a mixed diet, he's a non-alcoholic, non-smoker. Investigation done elsewhere, his HB ranged from the low of 4 to a maximum of 9.8. Total count platelets were normal, peripheral smear was microcytic hypochromic, stool local blood was positive, and stool micro showed no ova cysts. So these were the investigations that were done elsewhere. So when he came to us, he was afraid of the endoscope because 5 endoscopies were done on him. And the first was in July 2018. Antrum was inflamed, a clean based Alston antrum. 1 into 1 centimeter Forrest type 3, treated with anti-H. pylori. Second in August 2018, normal study. Third in November, a linear mucosal tear suggestive of malrevised tear, no active ooze, treated with PPI. A fourth one in December 2018, fifth one in February 2019. He also got a colonoscopy in November 2018 elsewhere, which is normal. A CCT abdomen, oral and IV contrast was done in November 2018, again was normal. Elsewhere, he got a capsule endoscopy done in November 2018, and he did not have the video recording, the pictures of it, he just came with the report. That was shown as revealed no mucosal abnormalities and suggested repeat study. So he came to us, moderately built and well-nourished elderly man, BMI of 20, pallor was present, pulse rate of 90, BP 110/70, oral mucosa was normal, per abdomen was normal, PR examination, melena was present, respiratory system was normal, JVP was elevated, and CNS residual left hemiparesis. Investigations, HB of 5.6, total count platelets were normal, peripheral smears for microcytic hypochromic blood picture, iron studies suggestive iron deficiency, RFT and LFT were normal. So here we have a patient, obscure overt GI bleed, elderly diabetic, and an old CVA residual left hemiparesis on antiplatelets. So investigation, we started the OGD scopy. Again, he was terrified seeing the scope, as I told earlier. We saw a linear mucosal tear extending from the OGJ to the cardia with minimal ooze. So rest of the study up to D2 was normal, no altered blood seen. We treated him with adrenal injection therapy and IV PPI, changed to oral, and he was kept on a dose of sucralfate and advised to review after 2 weeks. As expected, melena again. So the repeat OGD scopy after 2 weeks was normal. Colonoscopy again was normal. we did a push enteroscopy in him, and we could only pass up to 40 centimeters beyond the duodenogenital flexure. No lesion, no fresh or altered blood seen. So what did we go with next? We had options of repeat capsule or a CT enterography. Fine, we went ahead with the CT enterography, and this is what we saw. So a small nodular area of enhancement noted in the non-dependent portion of the proximal jejunum, seen prominently in the arterial face. So we traced the feeding artery. When you start tracing the feeding artery towards its origin, it seemed to develop, it was coming from the SMA. So this is the root of it, traced it to the SMA. And the draining vein. So again, you can see that the draining vein, you can see that it's the arterial face where we are seeing the draining vein. Traced it, and this is a coronal image which is showing the feeding artery and the draining vein in the same shot. So venous and delayed phases were not significant. So here we have a case of a jejunal arteriovenous malformation. So we discussed with the patient regarding his disease and on various treatment options, and he was taken up for mesenteric angiography and embolization of the AVM. So we did a selective SMA catheterization. This was done with the help of the interventional radiology department, and we called them in to help us with this case. They came over happily, and we proceeded with an angiography. You can see the SMA. I don't know how clear it is over here. So you can see the these two feeding arteries were only seen on the angiography. It was not seen on the enterography. So two small feeding arteries, and you can see on the extreme right a blush which is suggestive of a jejunal arteriovenous malformation. Feeding arteries were embolized using 2 mm coils, platinum coils. The first one you can see in the first picture, and after the second one, after contrast, you can see that the blush has disappeared. So the patient came for review after 1 month. We had given him iron infusions. His HB was 14. He was hale and hearty. He was doing well. The greatest HB that he has seen was HB of 14 grams. He did not have melena, and it just shows that the importance of radiology in bleeders, and which can never be overemphasized. Briefly on small bowel bleeding, a relatively uncommon event accounting for 5 to 10% can present as overt bleeding or occult, remains a diagnostic and therapeutic challenge. So as you all know, the ACG guidelines approach to small bowel bleed, occult overt, ours was overt, repeat endoscopy if warranted. We did that, negative, proceeded with small bowel examination, video capsule endoscopy was done outside. We don't know how well it was done, but however it was done, it was normal. We went ahead with CT enterography. CT enterography was negative, further evaluation was warranted. CT enterography was positive, and then we went ahead with the specific treatment. So basically, small bowel bleeding, angiodysplasia, which is characterized by focal accumulation of abnormal dilated and tortuous blood vessels, most common cause of small bowel bleeding. So angiodysplasia is basically a broad term for arterial vascular malformation. So it can be an angioectasia, it can be duodenal lesion, it can be AVM. Now AVMs are quite rare on the small bowel. It's common in the colon, but very rare, especially in the elderly, in the small bowel. And venous lesions include venous angiomas and small bowel varices. Causes of small bowel bleeding, numerous of them are, I'm not going into detail due to lack of time. And classification of AVM based on Moore classification is classified into 3 types, type 1, 2, and 3. 1 is common, it's an acquired disease, occurs mainly in the elderly patients and frequently appearing in the right colon. Type 2, congenital, in the younger patients, rarely in the elderly, in the small bowel. And type 3 in patients with hereditary hemorrhagic telangiectasia. So in this patient, we did not have an endoscopic picture of the AVM. But I'm just putting this up so that we all know that endoscopic classification of small bowel vascular lesions. So this classification is basically made so that because treatment for each is different. So types A1 and B, that pathological correlates to angioectasia, type 2A and 2B, pathologically correlates to duodenal, and ours was 3. So that is endoscopically treated with endoscopic clipping, hemoclips, banding, Sometimes sclerotherapy and surgery is the definitive treatment. This is what is given in literature. So this is the just pitch for literature reviews of arteriovenous malformation, a capsule image, an endoscopic image, a post-op specimen, and HP image. So the diagnostic modality for AVM, arterial lesions include the Delafoy and AVM, and they brightly enhance during arterial phase and become faint or in delayed phase. Most small bowel AVMs range from small, that is less than 2 centimeters, to large lesions. Ours was a small one, but caused quite a significant bleed in the patient. Now, video capsule endoscopy versus CT angiography. So this is quite conflicting. Both, as we have heard in earlier ISG meetings itself, once even Basumani Hassa had told during one of his class on obscure GI bleed that both complement each other. So like the same way, even this, they complement each other. So there is no, you can't say one is superior over the other. But CT angiography tends to score more over video capsule endoscopy for detection of small bowel tumors. And for small vascular lesions, angiectasias, capsule endoscopy tends to score higher. And small AVMs are easily missed on endoscopy. Probably this is what happened to us, because in our push enteroscopy, we went up to 40 centimeters. The radiologist told it's at around 40 to 50 centimeters from the DJ flexure, but we missed it. Probably it was somewhere in a mucosal fold, or probably we would not have reached up to the lesion. So treatment of intestinal AVM, small AVMs that are detected endoscopically as flat or mildly elevated hemorrhagic spots can be treated using mechanical hemostats with endoclips, or even small flat ones can even be treated with the APC. Mesenteric angiography and subsequent microcoil embolization is an effective modality of hemostasis. And microcoil embolization in hemodynamically unstable patients is what is described in literature. This procedure is done in unstable patients when they're bleeding and for stabilizing them for surgery. But here, in our case, the patient was not willing for a surgical management, so we gave him a treatment. It's now almost 6 months since we did this, and he's really good, he's doing well. He's come to our OPD 2 weeks back, he came, he's doing really well. So obscure GI bleeding is always a challenge, be it diagnostic or therapeutic, and especially when source of bleeding is noted in the small bowel AVMs is a rare cause of GI hemorrhage. And a timely intervention with an algorithmic approach and multidisciplinary care needs no further emphasis in this case. Thank you.
Good evening to everybody. The case is a case of unmasking the decompensation. I would like to start with the case. This is a 56-year-old male from Cuddalore who presented with complaints of fever on and off for 2 months, yellow discoloration of the skin, eye and urine for 15 days, and abdominal distension for a period of 10 days. The fever was continuous, low grade and not relieved by antipyretics, and it lasted for 2 months. He also says for the last 6 days that he complained of fever with intermittent spikes with chills. And this overall was associated with fatigue and loss of appetite. The jaundice was insidious in onset and gradually progressive, and it was not associated with any pruritus, leg ulcers, or pale stools. The abdominal distension was progressive and associated with mild intermittent pain in the flanks. He also noticed that he developed swelling over the lower limbs, which was up to the level of the knees. There was also a history of altered sleep pattern for a period of 2 days. He was diagnosed with chronic liver disease, likely cryptogenic as told by him, last 1 year back. There was no history of any GI bleed, blood transfusions, no history of any recent travel, pet exposure, rash, weight loss, or any other systemic complaints. He was taking homeopathy medicines for osteoarthritis for the last 3 months. The family history was not contributory, and he denies addictions in the form of alcohol. On examination, his vitals were stable, and there was presence of pallor, icterus, pedal edema. There was no lymphadenopathy. There was presence of ascites with splenomegaly, and flaps were present. So we had a case of decompensated chronic liver disease in the form of ascites and jaundice, with maybe ACLF also, with portal hypertension, with hepatic encephalopathy, likely precipitating cause being SBP. We also had pyrexia of unknown origin for a period of 2 months, which needed evaluation, and a component of drug-induced liver injury could not be ruled out. The investigations were suggestive of pancytopenia, direct hyperbilirubinemia, and some transaminitis. INR was 2.35, which brought his Child-Pugh score to C13, MELD sodium of 28, ACLF grade 1, and the alpha fetoprotein was normal, and the corrected retic count was also normal. The ascitic fluid analysis was suggestive of high SAG, low protein ascites with evidence of infection. The WBC count was 8,000 neutrophilic. The cultures did not show any growth. Because of pyrexia of unknown origin, we also worked up for HIV autoimmune workup, which was negative. The blood and urine cultures were also sterile, and the thyroid profile was normal. So we treated him with antibiotics, liver support medication, and anti-NCAF measures, but the low-grade fever still persisted. On investigation further, for evaluating for pyrexia of unknown origin, we also wanted to rule out any myeloproliferative disorder. So the transferrin saturation was 8.5%, suggesting iron deficiency. LDH was high, and the ferritin levels were 5,113. So we by now had thought of hemophagocytic lymphohistiocytosis, but the factor that didn't go in favor of that was a bone marrow which was hypocellular, which was done outside, and the triglycerides were also normal. An ultrasound of the abdomen was suggestive of some parenchymal liver disease with features of portal hypertension, and a small hypoechoic lesion in the right lobe of the liver. The CT scan shows it. There's small right hypoechoic lesion about close to 1 centimeter in the right lobe of the liver, and it also showed features of portal vein dilatation, suggesting portal hypertension. The CT chest was done to rule out the causes of secondary HLH, which was done again outside, and it was suggestive of some left axillary lymphadenopathy. When the patient presented to us, we decided to investigate further, and a repeat bone marrow aspiration and cytology was done, which was suggestive of increased macrophage activity with hemophagocytosis, thereby clinching the diagnosis of HLH, and this was establishing secondary HLH most likely in this patient. So the patient was started on steroids, but fever still persisted. So we again repeated the paracentesis, now showing normal WBC count. So a PET CT was done, which was suggestive of multifocal FDG avid areas in the right lobe of the liver in segment 8, 5, and 6, segment 6 being the largest with a SUV max of 7.73. And some segmental uptake in the proximal transverse colon as well. This just shows the high FDG uptake lesions in the liver. It also shows an enlarged lymph node in the supraclavicular lesion and some multifocal patchy FDG avid uptake in the D12 vertebra, bilateral iliac bones, and the femur bone. So colonoscopy was initially done, which was normal, and upper GI endoscopy was suggestive of small esophageal varices with mild portal hypertensive gastropathy. So we proceeded to biopsy the liver lesion, which was done under ultrasound guidance, and the liver lesion biopsy was suggestive of atypical lymphoid infiltrate. So IHC was further suggested, and the IHC, the lymphoma panel was suggestive of CD20, 30, PAX5, and CD68 positivity, thereby confirming a case of classical Hodgkin's lymphoma. So we now have a case of classical Hodgkin's lymphoma with secondary HLH, in a case of SBP with CLD and portal hypertension and hepatic NCAF, which was treated. So the treatment given to this patient was injection dexamethasone and 2 cycles of ABVD with 50% reduction of the doxorubicin and vinblastine dose in view of his CLD status. The patient is stable, afebrile, and he is gone home, and his next cycle is planned on 26th of this month. The repeat testing was done as ferritin is a prognostic marker. It showed decrease in the level of ferritin and resolving LFTs. So just a short note on HLH, it's also called hemophagocytic lymphohistiocytosis. It's an aggressive life-threatening condition, which is primary in case of a genetic mutation, secondary in case of a trigger like infection, autoimmune disease, lymphoma, leukemias, and macrophage activation syndrome, which is mainly seen in rheumatological conditions. Most of the data what we have on HLH is based on a 2004 study, which lists out the various symptoms, signs, and what we can see in the blood tests in these patients. Basically, liver involvement is nearly universal in these patients, and most of them present as hepatitis. Liver enzyme levels will be raised to the tune of more than 3 times upper limit of normal in more than 50 to 80 to 90% patients. LDH is elevated in 85% patients, and bilirubin levels are to the range of 3 to 25 milligrams in more than 80% patients. Hypertriglyceridemia may be seen in the later stage in these patients. The diagnosis, a molecular diagnosis, if it's consistent, it will prove HLH, or 5 out of 8 criteria are necessary in the form of fever, splenomegaly, cytopenias, hemophagocytosis of the bone marrow, ferritin levels. 5 of these criteria were present in the patient. The approach in general is to involve the hematologist right from the beginning and to search for a triggering condition. If the patient is stable, we treat for the triggering condition. We can start with steroids or etoposide, and if there is CNS involvement, then intrathecal chemotherapy is warranted in these patients. Further deterioration will require a hematopoietic stem cell transplant. The prevalence of liver involvement in Hodgkin's disease, as per AASLD, is described as 5% in liver biopsies to as high as 60% in certain autopsy series. We have case reports and series ranging from 1978 onwards describing HLH secondary to Hodgkin's lymphoma. So there are just some case reports of Hodgkin's lymphoma presenting as ACLF. And although it is a rare entity, I couldn't find anything on secondary HLH with underlying CLD. This is without viral markers positive. This is the first patient whom we saw in the case report. Thank you.
Questions after the session. I request Dr. Vinod Kumar from GEM Hospital to have the presentation.
Case of obstructive jaundice. Let me start with the case history. He is an 87-year-old gentleman. He has presented with multiple comorbidities, diagnosed with periampullary malignancy, inoperable in 2017. He was previously stented in 2017 with biliary Sims. He had a stent block in 2018. So we have deployed another stent within the first stent. In March 2019, he again developed a stent block. At the time, the patient was very sick. We just inserted a plastic stent inside the two metallic stent. The two metallic stent was found to be blocked. So there was no space to negotiate the scope in D2, and patient was very sick. So we have inserted a plastic stent with within the two metallic stents, and patient improved and went home. And after 3 months of the deployment of the plastic stent, he again presented with a stent block. This was the second when we inserted a plastic stent, and almost 2/3 of the lumen were blocked. So with greater difficulty, we have passed a second plastic stent, first plastic stent. Again, he has presented with a stent block. So now what to do? We have these options available. Can we try an ERCP and another stent placement to take out the plastic stent and third stent in the ampulla? Or can we subject the patient for a PTBD? Or can we try an EUS-guided hepatogastroscopy, or can we hand over to the surgeons? Initially, he was planned for an EUS-guided hepatogastroscopy. During EUS, we found out he had an atrophied left lobe. We couldn't puncture the segment 2 and 3 ducts, so this procedure was deferred. Then we have planned for an EUS-guided cholecystogastroscopy with hot axios. A word or two about hot axios. It's an electrocautery enhanced device. It's a single-use, doesn't need a guide wire, doesn't need dilatation. So we use this device for cholecystogastroscopy. A small video. This is the dilated pancreatic duct we are visualizing in the body of pancreas, and this is the atrophied left lobe of liver. Below is the portal vein and below is the dilated CBD. Since the left lobe is atrophied, we couldn't further proceed with an EUS-guided hepatogastroscopy. With the Doppler, we can clearly see the portal vein, and below is the dilated bile duct. The bile duct measured around 20 millimeter. This is a dilated pancreatic duct. This is at the level of ampulla. We can clearly see the two metallic stents there, which is blocked embedded within the tuber. Here we can see the gallbladder very much distended with a lot of sludge in it, and we have measured the distance from the stomach wall to the gallbladder wall. It's less than a centimeter. This is the portion where we are trying to puncture this gallbladder in the antrum. We could see a lot of sludge, so we used a bigger hot axios. Conventionally, 15 millimeter hot axios was used. Here, because we see a lot of sludge here, we used a 20 millimeter hot axios 20 millimeter hot axios is used only for US guided GJ. Since we see a lot of sludge here, we used a 20 millimeter hot axios. We have punctured with hot axios. The stent was inside the gallbladder wall, and the umbrella, the distal flange was opened. And we pulled the flange and we released the proximal flange through endoscopic guidance. So after seeing the endoscopically, we have deployed the proximal flange, and a lot of bile gushed into the antrum. We could clearly see. This is after deployment of the hot axios, the CBD was collapsed. And this, we could see some stone particles getting blocked into the hot axios lumen. So what we have done is we have used a CRE balloon to dilate these hot axios. We have dilated up to 15 millimeter so that the stones, all the sludge came out easily, doesn't obstruct the way. This is a D2 lumen. We are introducing a CRE balloon inside the hot axios. And then we have vented the gallbladder rumen to see what's happening in this. I mean, just out of curiosity with the forwarding scope we have vented. Just want to see how the cystic duct looks. Being a medical gastroenterologist, I don't, able to see the cystic duct, so we went with the scope to see how the cystic duct looks. Okay. So the advantages of heart attack is high success rate, can be done under sedation. It's a time-saving procedure, doesn't need a puncture, guide wire insertion, dilatation, and then introduction of a stent. It's just poke it and just release the stent. And lamps, since it's a lamps, there is no bile leak. The major disadvantage is cost, which is costing almost 3 times than conventional lamps. And sometimes if you misfire the stent, it can go into the gallbladder lumen itself, or come out from the stomach, or can release in the stomach wall itself. So when I searched literature, there are so many studies using, and they have done cholecystectomy using these lamps. These things I'm not, bemused, but some of the studies, they have used these lamps for treating gallbladder stones. It's new to me, and it was fascinating. So comparable with PTBD, US GBD scores more over PTBD since its PTBD was less durable, often required multiple interventions, whereas GBD requires only a single thing, and the initial benefit is post-procedural pain will not be there. This patient went home happily after 48 hours, and still for patient doesn't, initially his bilirubin was around 15 milligrams. Now it came down to almost 1.5 in almost 3 weeks. So far, it doesn't have any complication. It's dealing with it fine. It's past 3 months now. It's under continuous follow-up. Thank you.
Thank you, Vinod. That was an excellent demonstration. I think he's making waves in Chennai with his EUS. Congratulations again. And coming to both the presentations, I think both the presentations were very good. I think completely worked up, out of the box. But taking into consideration that patient benefit and how much out of the box we can think, I think the price was difficult to decide, but we decided to give it to the presenter from Apollo Hospital. Many congratulations.
Next, I call upon Dr. Ubal, our secretary, to give his report.
Good evening, respected senior members and friends. And we got a new members, Dr. Anand Vimalde from a gastroenterologist from CMC, Dr. UP Srinivasan is a surgical gastroenterologist from Chennai. So last year midterm accounts was submitted by Dr. Arul Selvan. We are given to our auditors for the accounting. Yet to receive account details from Madurai conference and Kanyakumari meeting. And as planned, the prevalence of rat killer poisoning research is going on across Tamil Nadu. At least 5 centers already submitted their data, and another 7 centers we are expecting by this month end. And if anybody is collecting the data, please pass on your data to this email ID. And January, we are planning a midterm INASL meeting with TNISG. So it is a single theme conference on hepatoma. That is on January 11th at Residency Towers, Chennai. And this is our first flyer which came out for the conference. And February, we are planning an IBD forum across Tamil Nadu. The date and venue will be announced. There's a request from Dr. Chandra Mohan. He's planning an Asia Pacific Gastroesophageal Cancer Congress on February 6 to 8, I think. And our annual conference is on March 7th and 8th at the Residency Towers, Coimbatore. So today, I think we thought at the year end, we are planning a celebration. Colonel Christian, our youngest member, becoming 90 few days ago. We from the department went to his house and cut the cake and celebrated. It is one of the joyous moments for all of us, and many more occasions to come, sir. Hearty wishes from the society. And again, second year in succession, Dr. Antia Memorial Lifetime Achievement Award from ISG. The second year in succession, last year Professor K.R. Palaniswamy got the award, and this year Professor Dr. Raghuram. These are some of the awards. I invite Dr. Raghuram to come over the dais, and last year winner Dr. Palaniswamy will give a moment of appreciation. Coming to today's meeting, this is the award which is owned by 3 individuals in India. Recently, Dr. T.S.C. got. 2 months ago, when we had a meeting, Professor Krishnan told that, why don't you call all the 3 and have a meeting? And that's how we initiated, and I thank Professor T.S.C. for initiating the meeting. And this is the award which is given, a Capstone Career Award, the highest honor bestowed upon individuals with exceptional professional and personal contribution to the field of gastroenterology. This outstanding dedication to the mission of WGO, and who has achieved distinction in such areas such as scholarly research, teaching, service to the WGO and the community at large. And it was given in conjunction with the World Congress of Gastroenterology, usually given to 5 to 6 persons once in 2 years, 1 awardee per continent. The awardees are entitled to the use of Master of WGO and the MWGO in conjunction with their name. And Professor Rakesh Tandon got the award in 2009, and this is some of the members who are present during that meeting. And thanks, sir, for coming us for our invitation. I think in spite of his bereavement in the family, I think he is able to come. We are very grateful to you. And if Tendulkar is for a god of cricket, if somebody is there, is endoscopy, if it's a religion, he is the god of endoscopy. And he's here and not yet came to the hall, and I think he's refreshing up, and he got the award in 2013. And our own star, Dr. T.S.C. got the award this year from David Jockman. And he was these are all the fellow awardees for this year conference. And T.S.C. also got the Community Service Award from President of ACG. And with that, I conclude, because we are running short, and I invite Professor KRP and Dr. V. Balasubramaniam to conduct the further proceedings.
This is going to be a lovely evening. one of the rarest event that is going to happen in ISG Tamil Nadu chapter ever since we became very active in 2003. And the elite persons in the field of gastroenterology in India, who are all being recognized by the World Gastroenterology Organization, great people like Rakesh Tandon sir, our good old friend Dr. Nagi, as rightly said, the god of endoscopy in India, and our own Chandubai, Dr. T.S. Chandrasekhar. You are all most welcome, sir. It is a prestige and a pride of the society to welcome you all, to felicitate our feelings, and it's going to be really a great event.
I would also agree with Dr. Bala. This is an important event for the Tamil Nadu chapter today, and we are looking forward to hear from all the stalwarts. We shall start with the first presentation. I think the speaker will be introduced by Professor Colonel Krishnan. The speaker is Dr. Professor Rakesh Tandon. He will be speaking on milestones in gastroenterology in India, hurdles and achievements.
I said, respected chairpersons sitting here, and ladies and gentlemen, when Ubal asked me to introduce a decades-old friend, Rakesh, to you, I jumped with happiness and gratitude. Now let me go, but the time is short here. This is Rakesh for you. Can I have something here? No? Okay. He is, after a distinguished career in the Department of heading the Department of Gastroenterology in the premier institution, Nalanda Institute. He retired in 2003, and his services were immediately commanded by the Pushpavati Singhani Research Institute, where he still works. No, it's okay. Now, before I go to the next slide, just now as I was talking to Dr. Mathan, it struck me, why should these people be retired and forgotten and discarded? Why can't their lifetime experience, knowledge, and wisdom be denied to generations of students that follow? They don't have to continue in the same chair, but services can be utilized by honoring them, asking them to come over some discussions, seminars, what have you. I don't know if that is, it should be officially permissible too. Now, Rakesh hails from a very distinguished lineage. His grandfather, Sri Purushottam Tandon, was a renowned freedom fighter in the days of the Mahatma and during the independence movement. He was also president of the Congress Party, and following him was Pandit Jawaharlal Nehru. That is, Purushottam Tandon was before Nehru, president of the Congress Party. Recognizing the yeoman services that he had done, a grateful nation conferred on him the most prestigious and the highest national award, Bharat Ratna. That's something great. Thank you. And also, posthumously, his memory has been etched in a postal stamp. That was great. Now, this is Annayam Pidavam Munnari Devam. Krishnarao, can you translate it for me? Can you tell him what it means? Now, all it means, Annayam is mother, Pidavam is father, Mun, first ever, Ari, the one who realized Devam, God. And I am grateful and pay my homage to this noble couple who gave us this illustrious son. Now, this is where Rakesh studied. This is where he did his basic MBBS and as well as MD later. He also got a gold medal. A good company, Rakesh. And before he moved to Delhi, look at this. I have one more word here. Look at the magnificent Mughal architecture with a British name, located in a city whose chief minister is a Hindu sannyasi. That is India. I hope India remains that way. And he moved on to Holiday Institute almost like a homing bird there. Starting at the lowest rung of the hierarchical ladder, he effortlessly climbed to the topmost post and occupied the post of head of the department. And throughout his career there, a lot of students have passed through them. They all remain grateful. I had known Rakesh at this institute. When I was doing PGI, DM gastroenterology in PH Chandigarh in 73, 74, Professor Chitani decided that not only postgraduates, certainly postdoctoral fellows should not be guided by just one set of teachers. That atherosclerotic, myopic, narrow view should not be the sole guideline for a student. So he used to send people around, and he sent me to All India Institute. I was there for 4 weeks, and my comfort zone was Rakesh and my good friend MP Sharma. The teaching was excellent. I learned a lot, but there was a certain intimidating ambience from which I needed protection, and Rakesh gave me a lot of it. Subsequently, when I was posted to Army Base Hospital, Delhi, after obtaining the DM gastroenterology, I was almost part of All India Institute gastroenterology department too. And they used to come over, I used to come, and we used to take part in all sorts. So that's where I got to know him much closer. And, this is the number of societies that he is a member of. And, I don't have to read all of them. Which one should I say? Japanese Society of Gastroenterology, Italian Society of Gastroenterology, Indian Society of Gastroenterology. He was president, secretary, member, and I remember I think I was president and you came next, isn't it? Oh, that's right. Okay, that's one achievement. Look at the number of research papers. It is 300 plus, it's still counting. And I went through it, runs to about 3 printed pages. Close to about 60 to 70% of them are from peer-reviewed international journals. And now this is a chapter in various books. And this is also so far touching 60 now. And in addition, he has written some books too. Rakesh, abhi kuch likho, hum swastha 2020 mein kaisa rahenge? Because things are getting bad for India. Now these are the other 2 books, and this is Acharya here. Subrata. Subrata is another jewel in the crown of Indian gastroenterology. So these are the 3 books he has written. Honorary positions, plenty. Editor-in-Chief of Journal of Gastroenterology. Now, I'll come down to the editorial board member of Scandinavian Journal of Gastroenterology. I don't know, in my days, Scandinavian Journal of Gastroenterology occupied as an important place as, say, NAGM or Quarterly General Medicine for general medicine students. That used to be a referral point. And to be an editorial board member there is highly, highly creditable. Then Journal of Digestive Disease, World Journal of Gastroenterology, World Journal of GA Surgery, and our own API. Awards. Well, Ubal has highlighted the Master of World Gastroenterology. That's age. Then the B.C. Rai Award, Emeritus Teacher Award, and my own mentor, by Dr. P. Chitani's name, there is an oration, and he delivered it. Lifetime Achievement Award from Indian Society of Gastroenterology, 2012. so many awards. At this time, may I recommend to the Tamil Nadu Chapter Executive Committee of the General Body that we introduce a set of category of members called honorary members. We enroll people who have distinguished themselves in this area, both inside the country, outside the state, as well as outside the country. And I'm sure, Rakesh, tomorrow when you go back, you'll carry this award also. Well, that's about all I have to say. And the topic given to you, you're about the best to do that because you've seen gastroenterology grow from its infancy to the gigantic proportions it has reached now. So, ladies and gentlemen, welcome, debonair, handsome, lovable, academician and teacher, Rakesh.
The idea of giving the biodata is to boost our youngsters to follow his suit and try to get as many degrees, as many recognition throughout the world. That's the main purpose. Not that we want to waste your time or anything. Please remember this is going to be something like a tonic in Sudan and the Murray. It's an youngsters. Sir, may we request you, sir, to enlighten us about the milestones in gastroenterology in India, hurdles and achievements. Welcome, sir.
Thank you, Colonel Krishnan, for that kind, very generous introduction. Reminds me of the old days that we spent together, and especially the first time that we were together in All India Institute, and I understand the environment there, and you mentioned it rightly. I was like a shield in between, between some tyrant. It's lovely to be here to see all acquainted faces, so many of them. I'm not going to name them, Dr. Krishna Rao, Malti, Jayanti, Advaitam, Professor Mathan, and of course the chairpersons, Dr. Palana Swami and Dr. Bala Subramaniam. I also like to thank the Indian Society of Gastroenterology Tamil Nadu chapter for having invited me, in particular, Dr. Kanan, the president, and Dr. Uval Das, the secretary. I'm amazed to see that the Tamil Nadu chapter is very active. Dr. Das described the number of activities that are in the offing, and I realized that this is probably the annual meetings. That's why the secretary's report was read out. But so many. Oh, monthly meeting, my God. That's amazing, you know. So this is very active chapter. I think very few chapters are so active as yours is. Congratulations for that. Well, the topic assigned to me is very simple because I only have to describe what I have gone through. My career as a gastroenterologist. After doing my MD medicine, I moved to the US to do my medical residency. And I had gone with the idea of going to cardiology. But during medical residency, I met with one professor, Walter Thayer, who impressed me very much. And he developed a fancy for me. He was a gastroenterologist. And this happened one case of particularly of amoeboma. This was a US veteran who had been to Vietnam, and he had all this diarrhea and nobody knew what would be the cause. They investigated, and I put in my finger and I felt some kind of a lump, and it just occurred to me this must be amoeboma, and certainly it was so. And he was cured. So that made me famous as a medical resident, that, oh my God, he made this diagnosis. I took up gastroenterology at that point on his suggestion that there are so many cardiologists, so many neurologists, but no gastroenterologists. The only gastroenterology in my alma mater was one single person who was a pool officer who only did sigmoidoscopy, straight sigmoidoscope. That's all. Well, when I looked at the scenario that time, there were a couple of well-known gastroenterologists, even in 1970, that is early, well, at end of 1969, and you can recognize all of them. In North India, Professor P.N. Chutani. In Delhi, Dr. B.N. Tandon. In Bombay, there were three, Professor Antia, Professor Vakil, and Pimparkar. Unfortunately, we lost him also very recently. In Madras General Hospital, Professor Madan Gopalan had a very active unit, but it was like he alone. And in Vellore, Sylvian Baker and the V.I. Mathan, whom we see sitting here, they were the ones who were doing active gastroenterology. In Calcutta, the only person I know of was Kamal Jalan, who had established a Kothari Research Institute. I couldn't get his photograph, so I can't show that. When I joined All India Institute, I joined in Department of Medicine. There did not exist any gastroenterology. It was the first time that in PGI Chandigarh, and I think simultaneously at All India Institute of Gastroenterology, Institute of Medicine, gastroenterology spawned as centers, although these were places where gastroenterology was very actively done. And then, of course, so many other centers came up, and at the present, there must be 30 centers of gastroenterology in India doing very active work. In Hyderabad, Asian Institute of Gastroenterology, in Madras itself, there are many places. Apollo is doing very active gastroenterology, and there are so many, I'm not going to name them. Okay, Vellore, of course, continues to be occupy a very dominant position in gastroenterology. If I look at the chronology of development of GI as a specialty, in 50s, infectious and parasitic diseases predominated. And then, of course, appreciation of tropical flu. Peptic ulcer disease was considered at that time a disease caused by stress, hyperacidity. My professor in Providence, Rhode Island, used to tell me that treatment of peptic ulcer disease is sedate him with phenobarbital to such an extent that he has a hard time to get up. He can barely get up, and then, of course, load him with antacids. We used to run a drip of antacids. That was the treatment. In 60s and 70s, when I joined All India Institute, we had a state sigmoidoscope, and there was a special table. You put them on like a reverse lithotomy position and do sigmoidoscopy. We had a semi-flexible esophagoscope, the so-called Eder-Hufford esophagoscope. That's what we used to do. I could hardly see anything. So you put in light and see something, let alone doing anything active. Anyway, in the 60s came up these diseases. Ulcerative colitis became recognized, and intestinal tuberculosis and was already there, but changed all over to Crohn's disease. In 80s and 90s, rapid development took place because of introduction of ultrasonography and video endoscopy. And then, of course, recognition of B and C and HCC. From 90s onwards, therapeutic endoscopy has taken the main role, and I'm going to leave that for Nagi to describe that in more detail. Now, look at this. In 50s, infection predominated. And what is it? We have gone a whole circle back. Again, now we are treating GI diseases by introducing bacteria, probiotics. We are doing fecal mycobacterium transplant. That is the way that we are treating. Isn't that a paradox? But then, of course, now the days are for biologics, DDRs, and liver transplantation. I'll just run through quickly some slides. Topic assigned to me is hurdles and achievements. I'll just summarize that. The hurdles were many, but basically it was lack of technology. We did not have no molecular biology, no genetics, or very poor genetics. Our biochemistry was preliminary, and of course the imaging techniques that are present today and helping us so much weren't there at that time. On the right side, you see achievements. Yes, so that also gave us an opportunity to improvise on things, and little bit of improvisation actually gave you a lot of happiness, success. So a little bit of activity, little bit of research that you did, an epidemiology that you did, or minor thing, modification of techniques, that gave you a lot of satisfaction. So at that time, even recognizing upper GI bleed and trying to stop that with adrenaline and all that was a great, great pleasure. Okay. So as I said, parasitic diseases predominated at that age. And which were the main parasite that we saw? Giardia, producing loose stools and distension of abdomen. Hookworm, causing severe microcytic anemia. Roundworms, intestinal obstruction, and a number of other symptoms. I'm not going to describe all that, but just trying to say that this was the main body of gastroenterology practice in the early 70s or late 60s. Certain anecdotes I'd like to just mention it. We saw an outbreak of ankylostomiasis, which I'll just describe. We actually published that also. Giardia, as I said, many people came with malabsorption, ultimately diagnosed with Giardia. We also described as what was the cause of Giardia causing malabsorption, what the pathogenesis of that. Ascaris, as I said, causing obstruction, high-titer disease of liver, other lungs, and all these. Neurocystosis, mimicking brain tumor, and visceral larva migrans, mimicking as liver mass. Look at these, multiple roundworms you can see, right from even in the stomach, and go on to the intestine. You see on doing a contrast CT, you can see so many of roundworms. We could see that on Bailey Meal study. I'd like to describe you, a patient walked to me in AIMS with 2 grams of hemoglobin. He was absolutely pale. 2 grams of hemoglobin, and I was surprised. Of course, he had a very high pulse pressure. I asked him what happened, where were you? He said, sir, many people have this disease in our village. So we further investigated. That person, of course, had a full load of ankylostome duodenale in his stool, had microcytic hypochromic anemia. Then we followed that up to his village to find out what are the other people. We found there were 20 patients who had the similar severe microcytic hypochromic anemia. And then when we investigated, we found out that they all had itching in the beginning. It just turned out that they played kabaddi. This was 2 teams of kabaddi, 11 each. And the kabaddi field was the one where earlier cow dung and everything, and also the night soil was dug in. And after that, they flattened it, and they made that as a kabaddi field. So that's where they were playing. The stool sample, the soil sample and the stool sample from these people all were full of ankylostomes. We report that in the American Journal of Tropical Medicine way back in 1971. Needless to say that deworming cured them all. We know that persistent intestinal bacterial infection can lead to a kind of partial paralysis of the small intestine. And that is what we understand about tropical is true. Of course, the master is sitting here, he will tell, but from South India, they describe these repeated epidemics of infectious disease, which were labeled as tropical is true because they were not just diarrhea, they did indeed lead to malabsorption. In North India, mainly Professor B. and Tandon worked on that, found that there were really no consistent infections, but all of them had protein malabsorption. So he labeled them as ITMS, idiopathic tropical malabsorption syndrome, as if not knowing the cause. But presumption was that this is really hyperproteinemia, and that hyperproteinemia does indeed lead to malabsorption. Sylvan Baker and Klipstein came up with the definition that if there is a malabsorption of two unrelated nutrients, you call that malabsorption. And indeed, similar phenomenon is noted following acute amoebic dysentery, because following acute amoebic dysentery, the colon also becomes something like paralyzed. Earlier, all bloody diarrheas were considered as acute bacillary dysentery. But the suspicion remained, especially for those who had had training abroad, that there must be some ulcerative colitis. Dr. B. N. Tandon described for the first time from my institute, in 1966, a series of 69 patients. 10 were infected, but 59 had ulcerative colitis, classical ulcerative colitis. Subsequently, another condition was noted was in non-specific ulceroconstrictive disease, the ileum, mostly in the terminal ileum. So we looked very carefully. The histopath was looked at by famous histopaths like Dr. H.D. Tandon and others, and there was no evidence of Crohn's disease. There weren't no granuloma. It just so happened that Professor Crohn himself came over to Delhi in connection with some conference. So we had him come to us, and he also sat through across the table with Professor H.D. Tandon, the pathologist who was doing gut pathology, and he said, yes, they are not Crohn's disease. Subsequently, however, Crohn's disease was described, I think first time from Vellore, if I'm right. Is that correct? From South India, I think that first series was from Vellore. And of course, Crohn's disease also was subsequently described from Ames, and the location was mostly in both the small intestine, large intestine, but also in large intestine alone. That seemed to be more common. Anyway, I won't go into that detail. Celiac disease got recognized. Earlier it was thought that celiac disease does not exist here, it's only tropical sprue, but we are seeing less and less of so-called tropical sprue now, at least in North India, and a number of series of celiac disease have come up, very clear that it's present in abundance. And then our good friend Helicobacter pylori has written Beating the Retreat. There is a time we thought that only peptic ulcer disease was caused by stress, but now we know that it's H. pylori that is the cause of it. And David Graham's famous statement that the only good H. pylori is dead H. pylori. So that's what we are doing now. We have number of regimens, this like anti-HP regimens. Just give 4 weeks of anti-HP treatment with these antibiotics and PPI, and the disease is cured. Whereas we used to take months and months to treat peptic ulcer disease. I'd like to say a few words about the famous work by Dr. G. Varghese from South India, who described this so-called tropical pancreatitis. And a few other countries, Ethiopia and a few other places, but mostly in tropical countries. And look at this chain of calcification along the pancreatic duct. Well, when we looked at, we found that world over there is chronic pancreatitis, and there was suspicion whether this is a distinct type or is it just some severe form of common chronic pancreatitis. So it turned out that in India, the incidence of chronic calcific pancreatitis is much higher than anywhere else. And we published that in 1998. 77 out of 100,000 were chronic pancreatitis patients, whereas world over, only 4.7 per 100,000 was the prevalence of chronic pancreatitis. Number of etiologies have been suspected for tropical pancreatitis. I won't name them, but let me just go over and say that now it seems clear that this basis of this tropical pancreatitis is simply genetic. We just have to identify which particular gene or which gene aberrations or mutations can actually cause chronic pancreatitis. At the present, we think that SPINK1 gene and cathepsin P gene polymorphism are the ones that seem to make people prone for developing chronic pancreatitis. And I know that at Asian Institute of Gastroenterology, where Nagi is the chief, there is a lot of work going on genetics of chronic pancreatitis. Gallstones. Earlier it was thought that gallstones are not very common, but we actually found that gallstones are pretty common. And when we did the studies, we found that gallstone prevalence in North India was about 5 to 6% of the population, whereas in South India it was only 1 to 2%. More studies were done, and we found, and Jayanti, we collaborated with Jayanti also to get some stones from South India and compared them with those from North India. We found that whereas in North India, the gallstones were predominantly cholesterol stones, in South India, they were black pigment stones. These are bilirubin stones. This was the difference that we found. Be that as it may, remember that gallstone is the major cause of gallbladder cancer, at least in North India, especially all along the Ganges. By the side of the Ganges, there is a belt of very high incidence of gallbladder cancer, and we believe that there is a mechanical irritation by gallstones on the gallbladder mucosa. This results into inflammation, proliferation, metaplasia, and then probably genetically controlled development of cancer. Chemical injury may also be present. Can I have a little water, please? Just somebody can give me a little water. Thank you. Okay. I would like to just mention the many liver disease things that came up, but two things that I like to mention. One is, thank you. Okay. And I like to say how an astute clinician can make some observation which would lead to a diagnosis or a new entity, diagnose a new entity. It was Professor K.L. Wig, director of AIMS, who actually said that, there are many patients who have cirrhotic type liver is enlarged, but and spleen is very enlarged. They have varices, yet they don't have no ascites nor any edema, and in fact liver functions were fairly well retained. What is this? Investigate this. So it's prior to my joining the All India Institute, Dr. S.K. Sama, who is senior to me, but he was in Department of Medicine at that time, he followed up these cases, and that is what led to the identification of the entity non-cirrhotic portal fibrosis. This is histologically, Dr. Nayak and Ramalinga Swami, they thought that this was really a recanalization of obliterated portal vein. So they labeled that as obliterative portal venopathy, recanalized thrombi, and by the time we see, it is the fibrosis in the space of Desai around the sinusoids. This is really, you can say, a slight extension of EHO, extrahepatic portal obstruction, blocking the splenic vein, and here, if you go inside and there you block, then the pressure on the spleen and the esophageal veins is lesser than that in EHO. But the liver function remained well maintained. Anyway, so this was one good entity that was described. And our center was described for the first time, the VOD, venoocclusive disease of the liver, which is now better known as sinusoidal obstructive syndrome. This is what we described from central India. And it was very interesting. We went there to do the field study and found that there was a staple food, a millet, that they were eating, and that got contaminated with a weed, and that contained pyroxene alkaloid. NASH and NFLD story, you know how things have changed. NASH did not exist, or we did not recognize earlier. Now it has come as a major problem for us, and that has actually become the major indication for liver transplant. I'll run through this. First, fatty infiltration, then inflammation, and then you lead to fibrosis. Liver transplantation, first described in 1955. Starzl did that in 1963, successfully, first time. That the first child that Starzl did actually died, but then that was a successful transplant, all right, although the child died. And after that, liver transplant took in a big way. And I'm happy to say that in India, during the last 2 decades, gradually more and more liver transplants have started occurring. In the second era, that is from 2005 to 2015, there has been a progressive increase and a phenomenal growth leading to about 1,200 liver transplants in a year. That's a huge number. And the results are very good too. 80% of them are live liver transplants, unfortunately, and only 15% are donor liver transplants. Delhi and Chennai are the centers doing the maximum number of liver transplants. Thanks to Dr. Mohammad Raila's center here, and in Delhi, the 2 people who are doing the maximum number are Dr. Soin and Dr. Subhash Gupta. The 1-year survival presently of liver transplant is 85 to 90% success. India has indeed emerged as a regional center for liver transplant in Southeast Asia. Approximately 25 to 30% of live liver transplants are performed on foreign nationals, particularly the neighboring countries, including Pakistan and Bangladesh and other places. Overall, good outcome. Survival is 85 to 90%, as I said. And the cost is obviously much lower than if somebody goes to Birmingham to get transplant done in QEH. Total number of transplants performed in India to date is close to 7,500. We should feel proud of the fact that we have become the leader in the Southeast Asia country for liver transplant. I'm just trying to tell what achievements we have made in gastroenterology and hepatology. And today there are 30 centers in India which are doing actively liver transplants. These are the large volume centers. In the end, I'd like to just say a few words about the role of stress in causing disease. It has not been so much recognized. We always just casually say IBS is stress-induced, but there are detailed studies now being done. And the fact that that emotions and stress can result into release of neurotransmitters, and that can affect the GI tract. It has been well recognized for a long time. Charak Samhita in 600 BC said mind influences the body, and the cause of disease is the separation of mind, body, consciousness due to degenerative effects of mental, emotional, physical stress. And in 128 AD, Galen, much later of course, passions or emotions would lead to development of disease. I said that. What is the root? How stress can cause disease. Why I said that is because with time, what has happened, we have become very technology dependent. What are the blood gases? Where's the blood chemistry? Come on, show it to me. Where's the chest X-ray? Ultrasound, CT scan, we see that all. But look at the patient. Believe me, I know of instances where glaring clinical features have been missed because you're focused on the imaging and laboratory. So that is what I like to highlight. Besides knowing your clinical medicine, besides knowing your pharmacology and giving them drugs, please put a hand on the patient and console him. This is one of the most important things that we need to learn. Very important. Personally, give him empathy must be shown. And that's why Francis Peabody said rightly, healing is best accomplished when art and science are conjoined, when body and spirit are brought together. The secret of care of the patient is caring for the patient. Thank you very much.
I would like to thank Professor Tandon for the excellent lecture on milestones in gastroenterology in India. I would like to thank you very much, sir, for the excellent lecture.